Ever wondered about the steps of an advanced trauma life support, ATLS? Well, you're in the right place. This process, vital in emergency medicine, can be broken down into a series of clear, easy-to-follow steps. Firstly, we focus on airway maintenance with cervical spine protection. The assessment stage includes ascertaining airway patency and rapidly checking for obstructions. In management, we establish a patent airway, perform a chin lift or jaw thrust maneuver, clear the airway of foreign bodies, and establish a definitive airway. This can be achieved either through intubation or surgical cricothyroidotomy. Following this, the cervical spine is maintained in a neutral position with manual immobilization. Next, we address breathing, ventilation, and oxygenation. During assessment, the neck and chest are exposed, the rate and depth of respirations determined, and the neck and chest inspected and palpated for any signs of injury, tracheal deviation, or chest movement. High-concentration oxygen is administered in the management stage, alongside the use of a bag mask device, the alleviation of tension pneumothorax, and the sealing of open pneumothorax. Circulation with hemorrhage control follows. Here we identify the source of external, exsanguinating hemorrhage and potential sources of internal hemorrhage. We assess the pulse and evaluate skin color. Management involves applying direct pressure to external bleeding sites, considering the presence of internal hemorrhage, and initiating IV fluid therapy with warmed crystalloid solution and blood replacement. The brief neurologic examination, or disability step, involves determining the level of consciousness using the Glasgow Coma Scale, checking pupils for size and reaction, and assessing for lateralizing signs and spinal cord injury. Finally, exposure and environmental control require the complete undressing of the patient whilst preventing hypothermia. Adjuncts to the primary survey and resuscitation include obtaining ABG analysis and ventilatory rate, monitoring the patient's exhaled CO2, attaching an ECG monitor to the patient, inserting urinary and gastric catheters, and considering the need for and obtaining AP chest and AP pelvic X-rays. Now we move to the secondary survey. Firstly, it's essential to gather an ample history from the patient, family, or pre-hospital personnel. AMPLE stands for allergies, medications, past illness, pregnancy, last meal, and events environment related to the injury. Next, you'll want to obtain a detailed history of the injury-producing event to identify potential injury mechanisms. The next phase involves a comprehensive assessment of the head and maxillofacial region. Look for lacerations, contusions, fractures, and thermal injuries. Reevaluate the pupils and level of consciousness, keeping the Glasgow Coma Scale score in mind. Assess the eyes for hemorrhage, penetrating injury, dislocation of the lens, and the presence of contact lenses. Evaluate cranial nerve function. Inspect the ears and nose for any cerebrospinal fluid leakage. And finally, check the mouth for signs of bleeding, soft tissue lacerations, and loose teeth. Management of head and maxillofacial injuries is next. Maintain the airway, continue ventilation and oxygenation as needed, control any hemorrhage, and prevent secondary brain injury. And don't forget to remove those contact lenses. Now onto the cervical spine and neck. Look for signs of blunt and penetrating injury, tracheal deviation, and use of accessory respiratory muscles. Palpate for tenderness, deformity, swelling, subcutaneous emphysema, tracheal deviation, and symmetry of pulses. Auscultate the carotid arteries for bruits, and don't forget to obtain a CT of the cervical spine or a lateral cross-table cervical spine X-ray. When it comes to chest assessment, inspect the anterior, lateral, and posterior chest wall. Listen for bilateral breath sounds and heart sounds. Palpate the entire chest wall and percuss for evidence of hyperresonance or dullness. Management may require needle decompression of the pleural space, tube thoracostomy, dressing an open chest wound, pericardiocentesis, or even transferring the patient to the operating room. The abdomen requires careful inspection for signs of blunt and penetrating injury and internal bleeding. Listen for bowel sounds and palpate for tenderness, muscle guarding, and rebound tenderness. A pelvic X-ray, DPL, abdominal ultrasound, or CT of the abdomen may be warranted. Lastly, don't overlook the perineum, rectum, and vagina. Assess for lacerations, contusions, hematomas, urethral bleeding, rectal blood, anal sphincter tone, bowel wall integrity, bony fragments, prostate position, blood in the vaginal vault, and vaginal lacerations. Next on the list of secondary survey is the Musculoskeletal Assessment. The 14th step of the ATLS secondary survey involves a thorough inspection and palpation of the upper and lower extremities. This includes looking for evidence of blunt and penetrating injuries, such as contusions, lacerations, and deformities. The extremities are palpated for tenderness, crepitation, abnormal movements, and sensation. All peripheral pulses are checked for presence, absence, and equality. The pelvis is assessed for evidence of fracture and associated hemorrhage. The thoracic and lumbar spines are inspected and palpated for evidence of blunt and penetrating injuries. A pelvic X-ray film is evaluated for evidence of fracture, and X-ray films of suspected fracture sites are obtained as needed. Moving on to the 15th step, the management of any identified issues begins. This may involve applying or readjusting splinting devices for extremity fractures, maintaining immobilization of the thoracic and lumbar spines, and wrapping a sheet around the pelvis, or applying a pelvic compression binder to control hemorrhage associated with pelvic fractures. Tetanus immunization is administered, and medications are given as indicated or directed by a specialist. The possibility of compartment syndrome is considered, and a complete neurovascular examination of the extremities is performed. Next, the 16th step involves a reevaluation of the neurologic system. This includes reassessing the pupils and level of consciousness, determining the Glasgow Coma Scale score, and evaluating the upper and lower extremities for motor and sensory functions. Any lateralizing signs are observed. The 17th step focuses on the ongoing management of the patient. This involves continuing ventilation and oxygenation and maintaining adequate immobilization of the patient. Finally, the 18th step, an adjunct to the secondary survey, involves considering the need for and obtaining various diagnostic tests as the patient's condition permits and warrants. These tests could include spinal X-rays, kinetic scans of the head, chest, abdomen and/or spine, contrast urography, angiography, extremity X-rays, transesophageal ultrasound, bronchoscopy and esophagoscopy. The key is meticulous examination, immediate management and ongoing assessment, ensuring optimal care for the patient in a medical emergency.